Good afternoon. I'm Dr. Phoebe Thorpe, and it's my pleasure to welcome you to CDC Public Health Grand Rounds for March 2015, Addressing Preparedness Challenges for Children in Public Health Emergencies. Few housekeeping slides here. Continuing education credits are available for Public Health Grand Rounds for nurses, physicians, veterinarians, public health educators. Please see our website for additional information. We are also on social media. If you want to check us out later, we are on the YouTube, the Beyond the Data clip. It has additional information about pediatric preparedness. We're also tweeting today, so please use hashtag CDC Grand Rounds for all your tweeting needs. We've also paired with the Stephen B. Thacker CDC Public Health Library to feature scientific articles related to pediatric preparedness. Please see the cdc.gov Library Science Clips website for the full listing. Here's a preview of our upcoming sessions. Please plan to join us either here or on the web. And I'd like to thank today's speakers for their collaboration in putting together today's session. And also, I'd like to take a moment to acknowledge the important contributions of the individuals listed here. Thank you. And now I'd like to introduce the CDC Deputy Director, Dr. Arias.
Thank you, and welcome all to today's Grand Rounds. If we're honest with ourselves, we have to admit that children frequently are not top of mind for most of us in the context of preparation for or response to disasters and public health emergencies. And that is unfortunate because we know that during the 2009-2010 H1N1 flu pandemic, young children and children with special health care needs were disproportionately affected. And even more recently, we know that by the end of February, 20% of individuals diagnosed with Ebola in West Africa were between the ages of 0 and 14. Children have different physiologic, developmental, and social needs from adults. And consequently, they have unique needs during disasters and public health emergencies that we need to recognize and we need to prepare for. Because of that, we have to take into account, and we have to make sure we take into account those differences and unique needs when we prepare and respond to all health emergencies. To date, we've made great strides in preparedness efforts for adults, but unfortunately, planning for the needs of children lags behind. A response that fails to prepare for children will not be successful. And a response that prepares for children will provide for better outcomes, not just for children, but for everybody involved. Now, the answer to this disparity is not necessarily going through a process of coming up with a plan or initiative that focuses on children. The answer lies in integrating the needs of children and the preparedness that must be done to address those needs in plans that we generally develop for responding to any emergency. Preparing for the needs of children need to be part of every stage of disaster response and included across all sectors, from large federal plans to local efforts, even for individual families, and we have to make sure that we let everybody know about that. At CDC, we are committed to ensuring the needs of children are included in emergency planning and preparedness efforts to safeguard them when disaster strikes. We've taken important steps in this direction already. So, for example, we have collaborated with the American Academy of Pediatrics to formalize clinical guidelines for the treatment and prophylaxis of children against anthrax. We've also worked through disaster scenarios with experts of the Association of University Centers on Disabilities in order to identify additional needs of vulnerable populations that should be addressed in emergency preparedness planning. Some of these efforts continue to date, and they include collaborations with other agencies and non-governmental organizations in a federal initiative to plan for children's needs in disasters called Children's HHS Interagency Leadership on Disasters, or CHILD. And we are continuing collaborations with the National Advisory Committee on Children in Disasters. Through events like today's rounds, we hope to spark more collaboration and more conversations with folks on the issue. I'd like to thank each of the speakers for championing the needs of children in disasters and collaborating with others to better integrate children into preparedness and planning across all sectors. Together with partners like these and others who are joining us today here in the room or virtually, we are making progress toward the integration of children's needs in disaster planning, and we really are looking forward to presentations, and thank you for your contribution.
Thank you very much, Dr. Arias. And now our first speaker is Dr. Georgina Peacock.
Hello, I'm Georgina Peacock, and I'm delighted to present to you today representing CDC's children's preparedness activities. To begin, I'd like to review some common terms and acronyms that are used in preparedness and disaster response. MCM are medical countermeasures, which are medications and vaccines that are used during public health emergencies. A pod refers to a point of dispensing, a place where medical countermeasures can be distributed to communities. ASPR is the Assistant Secretary for Preparedness and Response, which is both a person, Dr. Lurie, who we'll hear from later today, and also an office, which Dr. Lurie oversees. The NACCD is the National Advisory Committee on Children and Disasters, a preparedness advisory group for the ASPR. The NDMS is the National Disaster Medical System, which helps support a national medical response capability. And the AAP is the American Academy of Pediatrics. Public health emergencies can be caused by a number of different things. Outbreaks and epidemics of infectious agents, such as pandemic influenza, Ebola, or measles. Man-made agents, such as chemical, biologic, or radiologic threats, such as anthrax or a dirty bomb. And natural disasters with public health implications, such as earthquakes or hurricanes. To ensure that children are cared for in public health emergencies, we use an all-hazards approach to emergency planning. This means thinking about what might happen in a public health emergency and then identifying things that can be done ahead of a disaster to lessen negative impact. Some populations are more vulnerable to the effects of disaster and require special planning. While the focus of the presentations today will be on children, other vulnerable populations include pregnant women, older adults, and individuals with disabilities or chronic health conditions. Now let's turn our focus to children. Children's bodies are different from adults' bodies. This can be seen in the different rates at which they breathe. Children breathe more air per pound of body weight than adults. Children are more likely to lose body heat since they have thinner skin and a higher body surface area to mass ratio. In addition, they are at increased risk for dehydration. Finally, because they spend more time outside and they're closer to the ground, they're at higher risk for exposure to things both in the air and on the ground. This is further exacerbated because young children especially will put their hands in their mouths and objects in their mouths. Children's smaller size may necessitate the use of different equipment for medical care. You'll see here that the adult mask on this child covers almost his whole face and would not be effective in providing him the oxygen that he needed. In addition, clinical care, especially critical care, is different for children than adults. A clinician accustomed to performing certain procedures on an adult, such as intubation, may not feel comfortable performing this same procedure on a child. This calls for specialized planning to ensure that when there is a greater need or a surge for pediatric care, there are contingency plans for meeting the increased need. Medical countermeasures are items that state and local health departments could dispense as prophylaxis or treatment during a large-scale public health emergency. These would be distributed at pods, and you're going to hear more about this process from Dr. Chernak. Medical countermeasures must be adjusted for a child's age and size. A child who needs prophylaxis after a possible exposure to anthrax would need to take a smaller dose of medication than an adult This might be further complicated because he or she might not be able to swallow a pill, so they would need a liquid formulation of the medicine. Health departments need to provide different guidance to families and practitioners to ensure that children are receiving needed medications. These considerations require additional planning to meet children's needs in a disaster. CDC works to support the development of alternative and specialized guidance for children and medical countermeasures. Children may need help and support from their parents and caregivers. They may not fully understand how to keep themselves safe, and children and adolescents may take cues from others or wait to receive instructions during an emergency. If a child is hurt in a disaster, they may not be able to explain what hurts or is bothering them. Laws require an adult to make medical decisions for a child, and adult caregivers often advocate for the needs for their children. If children are separated from their caregivers, they may be less likely to get their needed care. Mental stress from a disaster can be harder on children. They feel less a sense of control, and they may not have the context to understand that situation will change, possibly for the better. It is very important to limit children's exposure to media during and after disasters. Following 9/11, television news shows showed images of the planes flying into the Twin Towers over and over again. Many young children didn't understand that this was a single event being replayed, but rather thought that there were many planes flying into many buildings. Involving parents is critical in making sure children are cared for in public health emergencies. Much like the shift to family-centered care in medicine, family-centered preparedness and response should be a priority for public health planners, families, healthcare providers who care for children. Parents and caregivers are the first line of response for caring for their children, and there should be a priority in planning and response efforts to keep families together. This is even more important in the care of children with special health care needs. These children include those with chronic, physical, developmental, and behavioral conditions that require services beyond general childhood requirements. In a 2009-2010 national survey, an estimated 15% of U.S. children were identified as having special health care needs. Our partners at Family Voices, a national organization that promotes quality health care for all children, have provided some stories about the importance of preparedness for families with children with special health care needs. One mother, Julie, evacuated when Hurricane Katrina hit. Julie's son, Zach, has spina bifida, so she always made sure that she had a week's worth of supplies and medicine for just an emergency. However, like many families, Julie and Zach were evacuated for much longer than a week. Now, Julie always maintains 1 month's worth of supplies just in case. Children and youth with special health care needs may have daily medications or might have a communication device or medical equipment to assist with mobility or communication needs. Families should think about situations in which they might need to evacuate or shelter in place for a prolonged period of time. A good rule of thumb would be to think about what one might need for 72 hours without assistance, or what they might need if they evacuate for a week to a month. It's helpful for healthcare providers to work with families of children with special healthcare needs to plan and prepare. As soon as possible after the emergency, one should work towards a new state of normalcy, reestablishing routine. For example, making sure young children's nap times are at the same time in the same place each day, or that older students return to school even if it's not in the same place. Pediatric preparedness is the key in an all-hazards approach to public health emergencies. Children have different physical and emotional needs which may require additional planning and different medical countermeasures, equipment, and guidelines, as well as practitioners to care for them. Children with special health care needs add an additional level of complexity which should be addressed during both planning and response. You'll now hear about some of the work that's being done to improve care in public health and hospital disaster response, and I'd like to introduce our next speaker, Dr. Mike Anderson.
Good afternoon. Happy St. Patrick's Day. For those of you that celebrate, I'm apologetic that I don't have any green on. I'm struck by a couple of things as I start my talk. First and foremost is really the makeup of the panel, and obviously it's an honor for me to be here. But this panel speaks of the power of coalitions. 2 federal officials from great agencies that are working every day to keep us safe, and then 2 folks from academia, from children's hospitals, from the medical school world. That really is the power of coalitions, not just for a good grand rounds, but really for us to continue to attack these problems. The second thing I'm honored with is always great to come and give a grand rounds where you learn more than you give. And I want to thank the team from this morning who's met with us and shared what's going on here with CDC. And I would agree that we're making great progress, but we still have much more progress to go. I'm an administrator of a children's hospital. I'm here to talk a little bit about what children's hospitals are doing, how we're partnering with quote-unquote, non-pediatric facilities, and then a little preview of the National Advisory Committee on Children and Disasters, which I'm proud to share. Well, first and foremost, I'm an optimist. There's good news. Kids are wonderful, right? Kids are resilient. They're healthy. Georgina did a wonderful job of outlining exactly what makes kids different. And typically, although 15% of the population has some sort of special health care need, very rarely do children need really intense children's hospital or intensive care services. Kids are very resilient. They bounce back from diseases that you and I would be devastated by. Kids are just wonderful. The great thing about being a pediatrician is you can show cute kid pictures for absolutely no reason in your presentations. I think kids are vulnerable. I'm going to talk about that. I'm a pediatrician. I believe it. But Dr. Lurie has also challenged me and my colleagues over the years to think about kids as a source of support and strength and resilience. I was honored to be at the White House a couple of months ago with several of you as well, where FEMA rolled out its youth preparedness strategy. We have to protect kids. That's one of my goals in life. But kids can also be an amazing source of strength for their family and their community as well. Likewise, our nation is blessed. We have wonderful children's hospitals, leading research institutions that day in and day out, like you at the CDC, like HHS, like ASPR, is really trying to improve the care of children. And more, although we're not where we should be, more and more these children's hospitals, these advocates are becoming involved in your world of disaster preparedness and response. And we also have great docs. We have great docs that are pediatricians, some of whom have been affected by disasters, that now are making this more and more their passion. So this coalition, which is represented by the group up here, is really growing in depth and breadth of our bench strength. But I'm also a realist. There is some bad news. First and foremost, kids are not often cared for in just children's hospitals. They're cared for in institutions that aren't always used to taking care of critically ill or injured kids. And those resources can become overwhelmed very, very quickly, even with just 1 sick child or 2 sick children. And 2, kids are very vulnerable. Once again, Dr. Peacock did a wonderful job of outlining, if you're not used to kids, if you don't have the right training, if you don't have the right stuff, whether you're an EMS squad or an emergency department doc or a transport professional, those kids can go downhill very, very quickly if you're not used to taking care of them. So kids can be quite vulnerable. The other bad news is, it's not really bad news, but we know, although there's abundant resources for children's hospitals, the places I work, the places Esther work, that most kids are cared for outside of those places in non-pediatric facilities. So that list of stuff that makes kids different, are we really assured as a nation when a family comes up to an emergency department or an urgent care center or a doc's office and they think, oh, thank goodness, I'm now seeking care, is that place really ready for one very sick kid? And previous disasters have not gone well. The good news is we're Americans, we learn from what happens in the past and we move on, but I still think there's much work that remains to be done. This is a little slide on H1N1, and we learned a lot. My children's hospital is in the middle there, Rainbow Babies and Children's in Cleveland, Ohio. I love the swine flu at the bottom left. That's probably not an official CDC slide, I'm sorry. But we learned a lesson. This was an interesting, I don't want to call it a warm-up because kids were very, very sick. Some children unfortunately died. Pregnant mothers were affected, as you know all as well. But this was a warm-up for the true power of coalitions and the true power of surge planning. In the middle is my children's hospital. There are 3 children's hospitals in Northeast Ohio. We got really busy really quickly. We were at about 104% capacity as H1N1 ramped up. We then said to our community hospitals, which are pictured there on the right, okay, what if we're full? What if this surge of patients, and you can insert God forbid, anthrax or some other event, what if the children's resources, which you're used to, are now full? How are you as a community hospital going to ramp up? Well, we sort of got the blank stare. Well, we don't admit children to our hospital. Yeah, but what if you're forced to? What if we can only take a certain triage level of kid that needs critical care services? So I think H1N1, once again, I wouldn't call it a warm-up, but I think it was a wake-up call for the pediatric hospital community and for the non-pediatric hospitals to sort of think, okay, how would we do this? How would we surge when we're not used to taking care of those kind of kids? So what are some keys to success? I was asked to talk about both. I served on the National Commission on Children and Disasters, and I'm now proud to be on the NACCD. What are some things that we can be doing in real time? Well, the first and foremost is each of these facilities, and we have to figure out how to, I guess regulate would be the word. Each of these facilities that's not used to taking care of kids, well, we need to ramp up that level of preparedness. The Joint Commission, certainly for hospitals and emergency departments from a regulatory standpoint, has a baseline that you should be at, but how do we ramp that up? How do we get prepared for what I call the disaster of one? That one really sick kid that comes in that really tests and strains the system. And do we have somebody in each of those institutions, what's called the pediatric liaison? I call it that noisy, annoying person that is always talking about the kids. Have we done a pediatric mock code? Is your PALS card dusty or is it actually current? Have we run through a mock scenario that involves children? And a case in point is the picture to the bottom right. I'm often reminded, a colleague of mine from Cincinnati is a pediatrician. He's really into these issues. He was asked to come to a mock disaster involving 2 buses at 8:05 in the morning. So he shows up. He's all enthusiastic. Okay, we're going to do a drill. This is awesome. Pediatricians here. Okay, 2 buses collide at 8:05 a.m. How many are children? And the planners go, oh, kids, huh? Yeah, we don't really do kids in these disasters. It's a bus at 8:05 in the morning. Who do you think's on a bus besides retirees going to the casino, right? It's obviously children. So with some cajoling and with some insistence, he got them to say at least 10 of them were children. Sick and injured kids can be very scary if you're not used to them. So we, once again, have to bake in readiness day to day. The second important thing we have to do is really the power of coalitions. And just to give a little plug, this coming November, we're holding a whole 3 days on pediatric coalitions out in Arizona. I am just tickled pink that we are getting some of the best people from across the country, not to talk about it as this pie in the sky concept, but really come together and talk about what is the power of these coalitions and how can we further a pediatric disaster readiness agenda. What do these coalitions do? Well, first they've got to define their boundary. Where is our coalition? What's the pediatric lead? And I would agree, not just to be a pediatric coalition, but to figure out how children are baked into each of these preparedness plans. What healthcare providers are part of this coalition? How do we reach out to other stakeholders such as law enforcement that are key parts of this? And then when do we ramp this up? When do we trigger? How do we do this? These coalitions are very, very powerful for kids. What's the staff, what's the stuff, and what's the space? How would we handle that bus accident? How would we handle Ebola viral disease if it started to affect a school? How would we do a mass casualty in our region? And the last 2 are very, very important, something that the National Advisory Committee is currently looking at and will continue to look at. What's the structure and the governance? Right now, coalitions are somehow very tight around medical schools and somehow sort of a loose coalition around emergency management planning. And then sustainability and funding. I know that resources are tight. I help administer at a hospital system, but how do we continue to find sources of funding so these coalitions can continue to do their important work? Are there examples of coalitions that are rock stars? Yeah, this is one of about 6 or 7 pediatric coalitions from across the country. This is from a dear friend of mine, Jeff Upperman, who's a pediatric trauma surgeon in Los Angeles. And I won't walk you through exactly what they've done, but briefly, they've gone through the region of Los Angeles, and maybe some of you are involved in this, some folks on the web as well, and sort of said, okay, what are the resources we have? What are the pediatric ICU beds, which are sort of the tip of that spear? And then what are the resources that we probably can't depend on to take great care of kids in an event? And they've labeled these hospital with tiers and now have standard operating procedures that as an event ramps up, the sicker kids go here and the less sick kids go here. Back to my analogy with H1N1, I think that's brilliant. I think that's great progress. But this is one region. Can we look across the country to Cleveland, to Chicago, to New Orleans, and make sure that this takes off and is much more commonplace? Finally, we need some governance, and I think one of the things also that my committee needs to look at is it's great that these folks come together, but I think they truly need leadership. And I think of things like the Children's Hospital Association partnering with ASPR and others to help lead this with colleagues like the American Academy of Pediatrics. And once again, it's funding. I know the CDC has been graciously funding many of these projects over the years, as has Dr. Lurie's shop at the ASPR. But I believe that these coalitions, if they're going to be successful, need ongoing leadership and ongoing funding so we can continue this important work. Finally, we need a pediatric voice. It's an honor to stand before you, and I once again would agree. I think we've made great progress because the CDC is having a whole grand rounds on pediatric readiness. More and more across the country, I think having pediatricians at the table is really important, whether it's looking at standards of care, whether it's looking at the Ebola response. We are thirsty and anxious to help in whatever way pediatricians can. And then finally, something on the National Association or the National Advisory Committee on Children and Disasters. Euphemistically, at the bottom, I have the baseline wonderful work that's gone on because we really do stand on the foundation of great work, whether it's here at the CDC, the National Commission on Children and Disasters, Dr. Lurie's shop. There's great examples over the past 5, 7, up to 10 years of great work. But on the left, it was sort of the current state. I love to celebrate when we have moved forward, but I think we can always get better. So how do we move from the left to the right, to a state where we're better coordinated and there's better coalitions? And if you look at the sort of the subsections, those are the areas that our committee wants to look at. But once again, it has to be a partnership between you all in the federal government and us in the private sector. So finally, 2 quotes. We really hope to bake pediatric readiness into routine regulatory planning. I believe that's the power of coalitions. And then a future topic, more and more we're concerned with population health, with making sure that we're looking at a whole community resilience. How can we continue to make sure that kids' needs are baked in there as well? It's now my honor to introduce Dr. Chernak from Drexel.
Good afternoon, and again, thanks to all of you for the opportunity to be a part of this forum and to really be a part of this tremendous panel of folks who've done such great work in the field of preparedness and also specifically pediatric preparedness. As you heard, my name is Esther Chernak. I'm a faculty member at the Drexel University School of Public Health. That's in Philadelphia, Pennsylvania, where I also direct the Center for Public Health Readiness and Communication. And today I'll describe a project sort of on the other side of the spectrum with respect to healthcare services for kids. I'll talk about a pediatric project to integrate primary care pediatricians into public health preparedness planning in Pennsylvania. The Pennsylvania Department of Health sponsored this project, which was a collaboration between our center at Drexel, the Pennsylvania chapter of the American Academy of Pediatrics, the AAP, and our goal was to build community preparedness in ways that help children and also to develop partnerships between public health departments and primary care pediatricians who work in ambulatory settings with the goal of engaging healthcare professionals who haven't really been involved in public health preparedness planning. To accomplish this, we took a systems-based approach to planning. We tried to clarify the roles of community practices in the context of public health needs during disasters that impact the health of children. And our final product was a strategic plan for the Pennsylvania Department of Health. To do this, we interviewed 36 subject matter experts who were practitioners in pediatric health care and public health. And our interviews were conducted primarily with practitioners in the southeastern region of the state, but did include several individuals from other areas of the state and also from government agencies across the state. We held 2 collaborative planning meetings with these and other stakeholders. In the first meeting, we reviewed our interview findings and asked for recommendations to engage community pediatricians into planning. And 6 months later, we presented a draft of the strategic plan to receive input. We learned that pediatricians had little understanding of how public health agencies are organized or how public health functions are handled between local and state health departments and CDC. They didn't appreciate the capacity and resource limitations that are often present in local health departments. And the pediatricians wanted more clearly defined roles during public health emergency response efforts. Many recalled their experiences during the 2009 H1N1 influenza epidemic and felt that their subject matter expertise in child health, as well as their insights into public perceptions and fears, were not engaged in ways that could have usefully informed public health policy. And finally, while they were committed to providing optimal, appropriate care during any disaster that impacted the health of their patients, they had little time and interest to devote to preparedness activities that they didn't feel were directly relevant to their practice activities outside of emergencies. Pediatricians also felt that during public health emergencies, their ability to communicate with patients was critical. we were told, patients want to know what I think they should do, not what the government thinks. They recognize that they were trusted experts who communicate with entire families, not just children, and as such they felt that they worked in the heart of communities. And to counsel their patients most effectively during emergencies, the pediatricians wanted real-time information, real-time situational awareness with a local emphasis and also pediatric-specific information. They also wanted information directly from government agencies coordinating response efforts, not the media, and they wanted information before their patients saw it on TV or heard it on the radio. Similarly, the public health representatives with whom we spoke had thought little about the roles of community pediatricians in disasters. They had limited understanding for how practices operate, how the public might rely on them, or the difficulties they might have expanding services during an incident that would increase either the demand for patient visits or even just information. They had also not considered the challenges that children with special health care needs face in disasters and did not appreciate that pediatricians might help address them. They had not planned for medical care outside of hospitals or points of dispensing or pods for mass vaccination or medication distribution. In general, the public health expectations for community practices were limited to physicians volunteering for medical reserve corps units or providing vaccines and reporting diseases. So with this information, the Pennsylvania plan defined clear roles and expectations for pediatric practices during emergencies. These include caring for patients in the ambulatory setting, offsetting the burden on hospital emergency departments. They include long-term monitoring for disaster-related health consequences, reporting diseases, managing behavioral health issues, and in general providing psychological support during and probably long after disasters. Pediatric practices will also provide their patients and families with health information. And most importantly, for the most part, this work will take place within the community offices where they work and practice every day. Pediatricians do have important roles to play during emergencies that require medical countermeasure distribution from pods or points of dispensing or medication centers. Parents will want their opinion regarding whether their child should receive the countermeasure. They want to know whether their health department what the health department is recommending, whether they should take it. In urgent situations, when medications are distributed quickly to thousands of people, they may not be dosed correctly for young children, and there may be insufficient supplies of suspension forms of medications. Community practices will be consulted regarding dose adjustments and home formulation of liquid suspensions. They'll also manage adverse events, drug interactions, and they'll monitor and manage the health outcomes of individuals after the intervention. So how do practices do all these things? Well, first, they need business continuity plans to ensure that they can stay open and serve their patients in the wake of disasters. And because immunization is such a major component of well child care, these plans will need to address the safe storage of vaccines during prolonged utility outages. Practices can risk huge financial losses if they don't have a generator or a plan to move their supplies to a safe location that is not necessarily the home refrigerator of the practice manager. Practices also need plans to increase appointments in response to a surge in demand for patient visits, and to also respond to the heavy demands for information and medical advice from families that are going to be eager to know the status of the practice and what they should do. This planning will need to include staffing and schedule modifications, as well as the use of communications technologies like voice and text messaging, websites, and social media. Right now, the capacity to use all these methods varies significantly across practices. Most importantly, planning should be coordinated with other entities to define roles and expectations in a disaster and to ensure communication between partners. If they're part of a larger healthcare system, primary care pediatric practices should be integrated into those systems' plans. They should also participate in the regional healthcare coalitions that are now being formed across states to plan for the health consequences of emergencies. Our stakeholders also felt that public health departments at the local and state level should have ready access to a cadre of pediatricians to call upon during disasters that impact the health of children. These so-called rapid response teams could convene virtually via conference call or webinar during an incident to provide health departments with a way to tap into the experience and knowledge of subject matter experts in child health and to ensure that there are community perspectives that are integrated and inform public health policies and decisions. Better communication in general is needed to improve coordination between public health and healthcare operations during emergencies. Existing state and local health alert networks generally do a good job of reaching hospital-based practitioners, but they need to be expanded to reach more community-based healthcare professionals. Conference calls and webinars that often take place during incidents to facilitate two-way communication should include community-based practices. Professional societies and the central offices of healthcare systems can also act as communication intermediaries between practitioners and public health departments. And finally, healthcare professionals should also have access to reporting lines in emergency operations centers and health departments. And during disasters that impact children, these emergency operations centers should be staffed by individuals with expertise in pediatric care. Good communication between public health departments and community pediatricians allows practices to play a useful role in the emergency risk communication that occurs during public health crises. This diagram demonstrates the complex but critical pathways communication pathways between local and state public health departments and between CDC, between practices in public health, and it also illustrates how the media obtains and provides information to professionals in public health, the healthcare, and the public. But pediatric practices also communicate directly with the public as well as with schools and childcare programs. They can amplify public health risk communication efforts and reinforce messages that are up to date, based in science, and specific for their patient population. Public health agencies should integrate this patient practice communication loop into their public information plans and be sure they have the capacity to share timely and relevant information with community practices. Studies have demonstrated that patients in general are more likely to have preparedness plans if their family physician encourages them to do so. And this is particularly important for children with special health care needs. Many pediatricians already work with their patients with special needs to ensure they have appropriate plans in place for emergencies, particularly those that disrupt electricity or require evacuation. Current healthcare delivery models, like the patient-centered medical home, offer additional staff resources to support high-risk patients. Electronic healthcare records can be used to create registries or panels of specific patients that can receive special communications or health interventions during an emergency, or to receive additional counseling and tools during visits, including care summaries, additional coordination with other providers, social service agencies, and even schools and child care programs. Yet despite these opportunities, there are a number of challenges that remain for community practices in public health preparedness efforts. In general, practices don't get paid to plan for emergencies, and every day they're busy with the work of seeing patients, implementing their electronic healthcare records, and interacting with insurance companies. Emergency planning is not a priority. And while activities like care coordination and counseling have recently become reimbursable, physicians may not use them to encourage emergency preparedness for their high-risk patients. In addition, professionals in both public health and healthcare systems need to understand better each other's missions and practice so they can work more effectively all the time, not just during disasters. Finally, it's challenging to measure the impact of emergency preparedness efforts in general, and this is also true for community pediatric practices. Process measures like writing or exercising a plan can be useful, but evaluating patient outcomes after an incident to assess the effectiveness of the plan requires a commitment to research and additional resources, which most community practices don't have. In Pennsylvania, the Pennsylvania Department of Health has begun to launch an interagency working group of child health and disasters to improve the coordination of all state government agencies that work with children. And this is a group that now includes key healthcare partners as well, like Pennsylvania chapter of the AAP, as well as the state's hospital and EMS professional associations. These pediatric healthcare partners and representatives from other associations also participate in the statewide advisory committee on preparedness that the Department of Health convenes. And the Department of Health has also sponsored conferences and trainings on emergency preparedness specifically for community practices and pediatric providers. And that also includes family medicine physicians who provide us a lion's share of pediatric care in the state of Pennsylvania, particularly in more rural communities. And the state's regional healthcare coalitions are also reaching out to include representatives from pediatric hospitals and community practices. In his study of children displaced from their homes after Hurricane Katrina, Dr. David Abramson described children as the bellwethers of recovery. They are uniquely vulnerable to the effects of disasters. Their health and recovery depends, but also reflects the health and resilience of their households and the neighborhoods, the systems in which they live. Because pediatricians relate to family, they often recognize dysfunction in children and adults, and they may be the first, if not the only, healthcare providers who address it. It is challenging for health departments to work with healthcare providers in outpatient or ambulatory settings. They're decentralized and they're hard to reach, but because they work in the heart of communities, primary care pediatricians are important partners in public health efforts to improve their preparedness and resilience. And I just want to acknowledge the many colleagues we had in the state AAP chapter, particularly Scott Needle and Amy Wishner and Suzanne Younghans for their visionary leadership. They taught us a great deal. And also my colleagues at Drexel and the State Health Department who helped us pull together these plans. Thank you very much. I'd like to introduce our next speaker, Dr. Lurie.
Thank you so much. So as you heard, I'm Dr. Nicole Lurie. I guess I am both a person in an office. Not quite sure what to say about that. But I thought I would just start because I suspect many of you have never heard of this office, the Assistant Secretary for Preparedness and Response, only to say that this is an office that came into being as a lesson learned after Hurricane Katrina. In fact, because Congress decided that there needed to be much more coordination of the public health and medical aspects of response. Our office brings together some really key components: policy and policy making around disaster preparedness, response, and recovery. An operations component, which includes not only an operations center for all of HHS, but running and deploying the National Disaster Medical System, and running the hospital preparedness program. And finally, a science component under which BARDA, or the Biomedical Advanced Research and Development Authority, I know it's a mouthful, is housed, but this is the entity that is responsible for the advanced development of the kinds of medical countermeasures that we might count on in one or another kind of disaster. So I'll just put that out there for context. Also, just put this for context in terms of the various kinds of disasters that we all deal with, and particularly highlight some aspects of these for children. So you've already heard about issues related to children during H1N1 and during Ebola. I point out that during the Haiti earthquake, we deployed the National Disaster Medical System there very quickly. They got there, and their real-time electronic health records told us that 40% of the people they were seeing were children with trauma. Well, we hadn't sent pediatric capable surgical teams, and we had to, really pivot on a dime and reconfigure our teams, which we were able to do. In the Deepwater Horizon spill, many, many people along the Gulf Coast were worried about their children being exposed to toxic chemicals and what that might do to their growth and development. And during the Japan earthquake and Fukushima nuclear plant meltdown, many people were concerned about what to do if children needed potassium iodide. And it turned out that there were 3 different protocols, none of them the same, for how you dose potassium iodide in a child. And the epidemic of fear, particularly on the West Coast, made it such that parents would not feed their children milk, went out and bought powdered milk and other sorts of things to protect their children, in this case from fear. During the tornadoes, and particularly Joplin, children came out of their bathtubs and from the mattresses over their heads to find bodies in the trees and were tremendously traumatized. And the Sandy Hook shootings and Boston bombings, I need to say no more. But it gives you a sense that in almost every one of these kinds of events, children are pretty disproportionately affected. One thing that was very clear from Hurricane Sandy, and gets to Mike's point about children as a source of strength, is when we communicated with very diverse families, children were often the only English speaker in their family and were the source of communication between any organized community agency or governmental agency and their families. I'll take just a moment to review some of our key accomplishments related to children and then go on to talk to you about some really exciting work that we're doing that very much relates to children and resilience. So one of the first things that happened when I came into this job is we realized that we had this very unrealistic separation between what it is that we do for children's bodies and what we do for children's well-being overall. And in fact, that was the same for adults. And so we set out to make behavioral health and social services very formal parts and components of our response, so that now whenever something happens when we mobilize a behavioral health team that is totally integrated now with the rest of our response, so that the behavioral health issues of everybody affected, including our responders, to be honest, are taken care of. Second, we started to compile and then annually coordinate HHS-wide activities related to children in disasters. And we were amazed at the departments and agencies and offices and some components where there are people doing amazingly creative work related to children in disasters. So there's a great forum now to bring them all together, to talk about them, to have them help each other and leverage each other's expertise, and put out annually something called the Child Report together with the Agency for Children and Families, that compiles and lists progress and sets priorities for the following year. As Mike said, we've now stood up a federal advisory committee on children and disasters. We've also focused very deliberately on stockpiling, on children's countermeasures, ranging from testing them, and how do you test them in children ethically, to stockpiling them and stockpiling them in pediatric formulations, to building new things like a pediatric capable ventilator so that the mask fits and that the lung volumes are appropriate for kids and all of those things. Being sure that all of our response teams are pediatrics capable, another key component of this. And I could go on and on, but I think I'd like to spend the rest of my time talking about issues like how do we know where the kids are, and how do we know where we have kids with particular needs. So this work about knowing who our populations are actually for me began a little bit over a decade ago with something that some colleagues and I started called the National Health Plan Disparities Collaborative. This was a collaborative of the 10 largest health insurers in the United States who all came together to try to address racial and ethnic disparities in their populations. And their first question was, for example, if we want to address racial and ethnic disparities amongst our patients with diabetes, how do we know where they are? And then, how do we know where people from different racial and ethnic groups are? So they took their claims data, and this figure on the left just is from one health plan, and they said, where are all of our diabetics in the Bay Area? And so those blue and purple dots are their diabetics in the Bay Area and people who had lipids checked and were either high or normal. They then said, wow, this is way too many people and way too many places to go to. What do we do next? And so they said, let's look at the census tracts with high numbers of people with abnormal lipid control in the Bay Area. And they were able to refine this a lot further. And then finally they said, well, we're particularly interested in Hispanic individuals with diabetes in Spanish-speaking communities. Where do we find those? And lo and behold, they were able to target in on a very focused area and put in place community interventions. Prior to this, I think the plan had been to send a letter to 10 million people, and one side in English and one side in Spanish. Would not have been a very effective intervention. Also turns out that we don't know where people with special needs are in general. So thinking about what could you do with claims data, we started thinking about, and I think as you heard from Georgina, in every, at least natural disaster, when the power goes out, we have people, children and adults, who are dependent on one kind of electrical device or other that get into trouble because the power goes out. And they have to pick up their equipment and go somewhere. Often it's not wired. They blow the circuit breakers. They get humiliated. They have to go to a place to take care of people with, quote, special needs. They're separated from their caregivers and family or friends, or they have to go to a hospital or a nursing home, something they've tried really hard to avoid. It doesn't, and then we send the National Disaster Medical System to take care of them. It's not a very tenable approach in the long run. We can build resilience in different ways. After the ice storms in New England, one of the health officers in a local health department commented to me that, gosh, you know, these people just came out of the woodwork. We never knew they lived in our community. And I was horrified to think that public health officers would not know who lived in their community. But the reality is they don't. And so we tried to figure out how could we help them learn who was electrically dependent on their community, who has oxygen concentrators or ventilators or is on home dialysis or this whole array of people. So we thought, well, Medicare buys most of this stuff. Why don't we go to CMS and see if we could use Medicare claims data to identify these people? So 6 months and 20 privacy lawyers later, we did a drill in the city of New Orleans. And we all went to New Orleans and we pretended there was a hurricane in a number of affected zip codes. Within under 24 hours, CMS had set up a password-protected website for this health department. They downloaded it, mapped them, and a bunch of us went around and knocked on people's doors. 94% of the time, we had the right answer, the right people, and the right medical equipment. And that's because this relies on claims that are 72 hours old. We've now scaled this nationally, And you will see over the next, hopefully, month or so, a zip code level map of people who are electrically dependent that health department planners could use to understand who of these people are in their community. And during disasters, we're now in a position to turn on the password-protected website so people can go and knock on doors of folks who are the most vulnerable. It also struck us that it would be great if their device could signal when it got in trouble, i.e. when the battery life was low. So this is a prototype battery signaling device built by an innovation fellow in our office using a $35 piece of computer equipment that many of you may know as Raspberry Pi, with a second component on top, which is also pretty cheap, which is called a la mode. So it's a healthy eating intervention. So here's a prototype battery signaling device that we are now taking to scale. And our goal is for everybody with at-home durable medical equipment to have a device like this built into their equipment. We've been working with NIST, the National Institute of Standards and Technology, now to have a national and maybe international standard for how everybody's equipment communicates out so that you don't have to have proprietary code for each of these. So watch that space. This then got us thinking to some of the other issues that have been raised here. Are claims data useful for us in emergencies in other ways? So certainly they would be useful for us before an emergency, and that's the kinds of things like drawing the map we just showed you. Could they be useful during an emergency or after an emergency as a metric? So I'm noticing that my slides got put out of order, but that's okay. Let's go back to our mapping thing for just a moment. In fact, I'll tell you what. Let me do this, and then we'll go forward. So could you use claims data before, during, or after an emergency? So we looked at this during Hurricane Sandy. We were curious to see what happened to patients on dialysis during Hurricane Sandy. Went back to CMS. Lo and behold, what did we learn? You see on the left a series of graphs for the boroughs of New York and New Jersey. The line at the bottom is what happens every day in terms of the number of people who get dialyzed. That thing, Storm Day, was a Sunday, and you can see a huge amount of dialysis on a Sunday that doesn't usually happen. People got early dialysis. It was really exciting to see. In order to make that a standard, we had to ask ourselves, so does early dialysis save lives? Well, sure it does. And we've just finished an analysis that shows us that if people get dialysis in advance of a storm coming, they have fewer hospitalizations, fewer emergency department visits, and are less likely to die. So now we have a pretty well-tested intervention, and we're able to look now after an event, getting to the point about metrics, to say, how do we do? How did the community do? And I'll challenge you to think about how we can expand this out for children in disasters. Oops, I'm going to go back. We've moved forward quite a bit with this work with claims data and this work with mapping. And now we use a platform called Med Map as a tool for routine response. So Med Map is a multi-layered mapping tool. And I'll just give you a couple of examples of how we use it. On the left is New Orleans and the Gulf Coast, and it tells us about the proportion of people who don't speak English and what language they speak. So during Deepwater Horizon, for example, when we had to respond, we were able for the first time to send responders whose language matched the language of the population. Really important for families without English speakers. It's not ideal to rely on the kids as the only mechanism for that kind of communication. On the right is some data from a recent power outage in the Michigan area, where we were able to look at where's the power outage, where are the hospitals. Now we can look also at where is everybody with medical equipment, and the health department can work with the power company to prioritize restoration of power. So just a couple of examples of how we can creatively use these kinds of methods and mechanisms going forward. I would submit to you that this would work with lots of different kinds of populations and lots of different clinical conditions in terms of public health response, and would look forward to talking to you about that. Where are we going with this? We've now used the CMS data to identify children with special health care needs who are on Medicare. Would love to have your ideas about how to get additional information to build into this so we can enhance pediatric preparedness. Michael also already talked about tapping into the strengths of children and defining developmentally appropriate response and recovery activities. And then finally, looking at innovation, particularly in the technology space with things like Raspberry Pi and other sorts of things, social media, to help particularly youth be much more involved in activities related to preparedness, response, and recovery. So you can find us of all of the normal ways. Thank you.
Thank you, Dr. Lurie, and actually, thank you to all of our speakers today for sharing really a great discussion of where we have been and where we're going with pediatric preparedness. And now we have, I think, time for a couple questions. If you have a question in the room, there's microphones on both sides, and then I think we also have some questions from our online audience.
Yes, from our online audiences. What would be the decision basis for allocation of limited pediatric ventilators in the event of a national respiratory pandemic?
Okay.
Sure. So I will say that the Institute of Medicine has done really tremendous work to define what we call crisis standards of care, to put together a framework for how you allocate all kinds of resources, including scarce ones, in an emergency. And that lays out a whole framework for communities to use. They've developed toolboxes and decision guides for clinicians, for EMS and first responders, and for others. And there's a set of really ethically established principles that take into account the values of the community and others to do that kind of allocation. And that would be the kind of allocation that would be used in a situation like a pandemic.
Do you have something to add? Yep.
Sorry, I would agree with Dr. Lurie in the fact that that's a wonderful document that's just brought some of the best ethicists and planners around. I do think it's now inherent then upon the local community planners to take great documents like that from the IOM and think about them and make them live and breathe, because I think oftentimes we've got great guidance. Now it's, I think, an important part of the coalitions to then make them a part of their everyday readiness.
Okay. Dr. Sossin?
Thanks to the panel. I know the Children's Preparedness Work Group was very anxious about putting on an outstanding grand rounds, and I think you did a fabulous job, and I appreciate all the presentations. My question relates to how we establish the value of investments in preparedness for everyday benefits to children's health. And I wonder whether the panelists could share an example of how work that they've been involved with around preparedness activities have led to better care of children in the everyday context.
Well, I'll just go back to my analogy of the disaster of one. I think there's a wonderful organization called EMSC, or EMS for Children. They've done a wonderful job of literally going through the nation and establishing what should an emergency department have for a disaster, for a large scale, but for the routine emergencies. And I think that sort of coalition between a pediatric expert organization like EMSC and then local owners of that emergency department, urgent care, whatever have you, I think that's an example of a powerful coalition on a very limited budget. EMSC is not really deep in money, but I think they've done wonderful work.
Yeah, I would also add, I think that the relationships that you build in the context of an emergency response tend to pay dividends during regular everyday operations, and that makes a huge difference. And I think in the context of practices, and even probably within hospitals, I think it's sort of the converse. I think the investments that are made in some of these newer technologies with respect to electronic health records, with respect to communications technologies, and even models like the patient-centered medical home, they probably pay dividends during disasters because they allow security of healthcare records so they're not in the basement being flooded, maybe they're in the cloud. And they also just allow for things like additional staff and ways to think about how to take care of the highest risk patients.
I think those are terrific examples, and I might offer some from sort of one of the most expensive aspects of what we do for preparedness, which is in the development of medical countermeasures of one kind or another. It's turned out that in the need to develop different formulations, for example, of countermeasures for children, we've developed better countermeasures for adults. that we've been, for example, been able to find formulations that not only kids can swallow, but because the little pieces are pelletized and can absorb more, that the countermeasure actually works better for adults. In the ventilator space, what's been really amazing is to get to a small portable ventilator, for example, that could be used for routine use. And not only is it pediatric capable, but it changes care for people at home because you've suddenly got a small device and it's not expensive. So it has revolutionized and will continue to revolutionize care, for example, for ventilator-dependent patients at home and care for their caregivers. You know, I think in each area of the countermeasure space, we are looking for a day-to-day, what I will call peacetime use, if we never experience a bioterror attack. The fact that we are now at a point where we're testing monoclonal antibodies for Ebola, a great example of broad public health use, both for adults and for children.
Again, from our online audiences, can you address how the CDC is working to relieve mental health effects in children as related to disasters?
There's work going on in the Children's Preparedness Unit to look at some of the needs of children in disasters, and we're working with partner organizations also to see how we can support children and families with our partners, both in the federal agency and nationally, to make sure that children's mental health needs are also addressed. As we heard earlier, we need to sort of look at the whole child and not divide the child up, but make sure that a child as a whole is cared for in a disaster.
And one more, how do you address keeping unaccompanied minors safe and accounted for, and also proceed with treatment?
I'll start, and then I'm sure others can chime in. It's really a nightmare for planners, right? If you have a child who hopefully is well and needs therapy, then separated from their loved ones. I think, once again, great guidance has been given by both the federal and non-federal partners. We've worked, a member of the National Commission on Children Disasters was the lead for the Center for Missing and Exploited Children. They have some pretty good standard operating procedures. But back to Dr. Lurie's innovation, we've actually seen, it's been trialed at Boston Children's, some facial recognition software that can help, if you prepare ahead of time, can prepare to reunite families based upon technology. So I would echo what Dr. Lurie said about we have to continue to push the innovation envelope.
And I'll just build on that a little bit to say, I think these issues about tracking and being able to account for unaccompanied children are terribly important. Sometimes we don't need things that are quite as sophisticated. That many kids are much more tech savvy than most of us adults. And they have pretty decent online social networks now and are able to communicate. We've been doing a lot of work with a number of the social media developers, and I was thrilled that just last week Facebook put together and issued a whole guidance document or a planning document for how to use Facebook during disasters, specifically because of the kinds of issues that have been encountered with kids and being able to reunite people who get separated, et cetera. So again, watch the space. I think on the technology side and on the social media side, there's a lot of exciting stuff going on.
Okay, thank you very much for joining us, and we'll see you next month.